is back. He
Stable, no problem.
stable, absolutely.
So I think when we start, it's best to off all our videos because that will lead to a more better streaming.
Good evening.
That we have none other than a very enthusiastic Dr. Rajiv Mukherjee, a member of the DOS, of course, and a cornea specialist running his own clinic, second generation.
But as soon as we on a pentacam which evaluates both the and the posterior surface, we immediately can see here that there's a posterior surface elevation or posterior surface ectasia. So this was a case potential for disaster, although it was a lip-smacking case for any refractive surgeon with such a low myopia. So it is that corneal ectasia diagnosis and management really cannot be relied upon with the placido topographer alone. So what are the qualitative criteria we follow to diagnose these cases in cases when we are trying to pick these cases up on placido corneal topography? As soon as we see the Myers, they are egged up. You can see the oblong Myers. These are a classical sign of corneal ectasia. There will be a localized area of power with concentric areas of decreasing power all around. An inferior and superior dioptric asymmetry. By that I mean, if you can, superior area is blue, which is flatter area. Inferior area is red or orange or yellow. These indicates a steeper zone. So there's an inferior and superior dioptric asymmetry. And what are the quantitative factors that we look for? If the is more than 47.2, if the difference between the left eye central keratometry is more than 1 diopter and the simulated keratometry values are more than 45.7. One of the pathognomonic signs defined by Rabinovitz et al. Long back was the skewing of the radial axis or the SRAX pattern. It says that any deviation from the principal meridian of more than 30 degrees is pathognomonic for diagnosing keratoconus on placido corneal topography. As we had seen for this particular lady, 26-year-old female, placido corneal topography was normal, but as soon as we took her to evaluate the posterior corneal curvature, we really found out that this was not an ideal candidate in touch with a barge pole on considering refractive surgery. So we need to see the posterior surface and what are the components of keratoconus. Now we'll be going certain slides where we'll be speculating different clinical conditions. So we know that the keratoconus is a combination of corneal thinning and corneal ectasia. None of them are exclusive or mutually exclusive to each other. And within that framework of ectasia, there is an anterior ectasia and the posterior surface ectasia. So I'll show you a series of slides now. On your left will always be a normal cornea for reference, and on your right will be a schematic diagram showing you a particular condition. Now, this is supposed to be what I'm trying to depict is a post-myopic LASIK, where we know that the anterior surface has been flat. Criteria of corneal ectasia. So now let's look at case of disciform keratitis, where there will be bulging of the anterior surface, but there will be no no thinning. So then again, we don't have both the factors together. A case of ophthalmos, where there will be a bowing forward of both the corneal planes, the anterior and the posterior corneal planes, but there is no thinning. Hence, we don't qualify it as ectasia. But if you get a case where there is isolated posterior bulging, no anterior involvement or anterior surface being where it was, we do have a case where it's a combination of bulging, that is ectasia, along with thinning. So this qualifies, and this is what we missed out on doing placido corneal topography alone. So these are the cases which are most vital and should have been picked up to avoid a disaster. So if this particular phenomenon is on, what will happen is you will have bowing or ectasia of both the anterior surface and the posterior surface, and only there is ectasia more in the posterior surface than the anterior surface. that will be the condition which will quantify or qualify a particular case to be called as a corneal ectasia with both the factors involved. So we use this device like Pentacam, Galili, or there are a couple of other devices which use the Schlein technology. And this, what I'm going to talk about, is the Pentacam on a Pentacam. This is a general refractive map. The best part about the Pentacam is there is no need to memorize or refer to any notes, no need to remember values. It's essentially absolutely intuitive. It just works more or less like a traffic light. You see a traffic light over here. Anything in the white is normal, yellow is in the borderline or suspicious zone, and red is absolutely normal. So you have your K values, your corneal thickness indices, your AC depth, you have your corneal indices over here. Anything yellow, as I said, is suspicious. Anything red would fall into the zone of being abnormal. Now, what most commonly used maps and very popular is the Bellin-Ambrosio enhanced ectasia maps, which actually give you a better insight and better diagnostic sensitivity into picking up these cases of corneal ectasia. Now, what that exactly tells us, you see two sets of corneal maps over here. The ones on your left side over here, where I have my cursor, is the analysis of the anterior corneal curvature, whereas the ones on your right side are the posterior corneal analysis. So, out of which this is the elevation, surface elevation maps, the anterior surface and the posterior surface. These are the enhanced best sphere maps, and I'll explain them in the next slide what that exactly means, and which actually enhances the ectasia for better sensitivity in terms of picking up these cases. And the third map is the difference between the first map and the second map, which comes out as the third map, which further gives us enhancement in terms of picking up ectasias. There are a number of values, the D values, which depict the front, the back, the pachymetry, the thickness values, the displacement of the thinnest point from the center, and number of them. And again, they are all color coded, and the timing of this lecture does not allow me to go much into the details. What is exactly a best fit sphere? The best fit sphere is something that you can see here, a yellow line, which calculates the corneal elevation values all across the surface of the cornea, be it the anterior or the posterior. And then an average of that brings out a spherical surface, which then when imposed onto the corneal surface, extrapolation will give us something like this, where you now have the amount of ectasia over the contact lens, best fit sphere contact lens, is much less as compared to somewhere here. And here what we are doing is, we pick out the thinnest and the most ectatic area of the cornea. We exclude a 4 millimeter zone around it. So that, in other words, we have just excluded the most ectatic areas. Thereby now when we calculate the values for our best fit sphere, they are going to be much flatter than what we saw in the figure over here. So once we have a flatter best fit sphere, the amount of ectatic cornea exposed above the best fit sphere is going to be much more. If you look at this diagram, there's a small pinnacle over here that you can see. But as soon as you see on your enhanced best fit sphere, as per exclusion of the most ectatic areas, you can see this exposed area much more. So this particular enhanced best fit sphere is going to be color coded in the hot colors, which is red, yellow, and orange. Anything below this particular best fit sphere, which is the flatter areas, are now going to be colored in blue and green. So now our red zone becomes much more prominent, right over here. So this increases the sensitivity of diagnosing these cases. Any and every thin cornea is not keratoconus. I'm just trying to show you an example. 446 microns cornea, and you see an absolutely normal progression map, absolutely, and there is no ectasia on the Bellin-Ambrosio display. Similarly, if you see a cornea that is 587 microns,
how is fellowship or senior?
if you see a cornea that's 587 microns over here, which is a thick cornea, that itself does not say that it's a normal cornea. You can see a slight amount of suspected area, which is ectatic, both on the anterior and the posterior surface. And these cases, rather than picking them up for refractive surgery, I would say wait for about 3 to 6 months and let's repeat the test and see what's happening. So there are numerous corneal indices, and you can just keep your cursor on them, and each of them will be displayed with the description on what they stand for and their normatives. And anything, as I said, it works like an intuitive traffic light. Anything in red is abnormal, anything in yellow is suspicious, and things in white are within the normal criteria. Now let's look at how do we diagnose post-LASIK ectasia. When we are trying to look for a case where there is an ablative refractive surgery being done, we have obviously altered the anterior corneal surface. So any analysis of the anterior corneal surface is not going to do much for us. So what we just have to look at is the posterior corneal curvature data, and that can be either compared with the postoperative maps, which usually are missing with the patient. So what we do is analyze the corneal surface, posterior corneal surface, on the refractive map and the bad display, Bellin-Ambrosio display. And never be fooled by the K values. The K values in close thoracic ectasia initially are always flat. So just be very careful about the K values. Don't go by the K values that they are flat and it can't be a case of ectasia. So once you take up these cases for Bellin-Ambrosio display, on the Bellin-Ambrosio display, just ignore the analysis of the front corneal surface. Look just at the posterior corneal surface. And there you'll find, if you find an area which is in red patch, that is, it calls in for a case which is a case of posterior corneal ectasia, along post-LASIK ectasia, and along all the D values, just look at the D value, which is goes hand in hand with the back surface, which is DB, and if that is color coded in red, you will know the amount and the quantification of the ectasia, and it does have a post ectasia. Now, what are the indices that should we look for? The multiple indices that I just mentioned, the Pentacam or any other system give you a number of indices, but the two most sensitive indices I do follow in my practice, the progression index. Anything below less than 1.2 on progression index is a normal cornea and should be considered for ablative refractive surgery, with other factors being normal. And the ART-max. Any ART-max values more than 385 are absolutely safe for refractive surgery. As I said, if the other things along with that are normal. Now, Bellin-Ambrosio Bellin ABCD staging. This is one way the Pentacam can give you quantification on the stage of keratoconus on the day of evaluation on your corneal tomographer. So what it does is it quantifies the particular stage on that particular day into A, B, C, and D values, where the A values gives you the anterior and the front surface analysis, the B is the back surface, C is the corneal thickness, and D is the distance visual acuity. So you get this, like this particular case is quantified as A2, B4 plus, C3, and D3. So now on, when we get on to analyzing this patient every 6 months or a year, we know whether this patient is doing better, improving, or decreasing. So we should, all those factors like wait for one diopter progression to be called. So all that is down the should not be taken up now. We have a much better way to diagnose. And this, if you want to follow this particular trend, and this just I'm showing you an A value done over 2 years. This is the baseline evaluation of a case of keratoconus, which shows you a value of 2.42. Now this hatched sign in between shows you an intervention. Now the intervention in this case on this particular date was a corneal cross-linking that was done. Then you see a value after 1 month, A value after 1 year, and A value after 2 years. So you get a progressive trend over time analysis for this particular cornea. Now, this gives you, I go further, and then show you that it gives D values, that is anterior, back surface, the cornea, distance visual acuity, and you can know what happened at each and pre and post intervention as well. So this ABC staging and ABC progression display are really in cases of managing, quantifying, and following corneal ectasias. Thank you very much.
Thank you, Dr. Rajiv. It's difficult to comprehend, to compress everything into a finite amount of time. You've done an excellent job, and we move on in the interest of time. Over to Dr. Balla to introduce our next speaker.
I think we'll have questions at the end of the session. Just one basic question which was being asked is it important to have lot many people may not be having access to corneal tomographer like Pentacam? Is it possible to diagnose Pentacam without these gadgets, or you need to have Pentacam?
It's not a question of Pentacam per se. You must have a system. If you're contemplating refractive surgery, remember it's an eye that is without any pathology, has just come in for a cosmetic procedure to you. And you must go to every extent possible on that day given technology to rule out any particular pathology that is pre-existing or contraindicated finding. Patient can be or can't be taken up for any refractive surgery. So I believe posterior surface corneal evaluation, there are numbers available. I personally use the Pentacam, and I'm sure there is no dispute on the fact that there is no doing a refractive surgery without posterior corneal surface evaluation.
Yeah, I think very well explained. Now I'll introduce our next speaker, Dr. Bharti. I think he does not need any introduction. Dr. Bharti was been past president of Delhi Ophthalmic Society, and he lot of first to his credit, sir. He started refractive surgery way back in 86, phaco in 94, lamellar keratoplasty in 95, LASIK in 98, flax in 2008, and he also is recipient of Hardia Award from AIUS in 2006, ST Award in 2015, Tahira Agarwal Gold Medal in 2004, Krishna Son Singh. I think the list is endless. And Dr. Bharti is going to speak on basics of collagen cross-linkings. So we are all eager to hear from you, sir. Over to Dr. Bharti, sir.
I'll share the screen now. And so I'll be talking about corneal cross-linking, basics of corneal cross. And as we have already heard, Dr. Rajiv, this is a group of disorders affecting the corneal shape, and it includes pellucid marginal corneal degeneration, keratoglobus, posterior keratoconus, in addition to keratoconus, which is our main focus right now. And basic is that there's unstable refraction, where refraction should be stable, and especially the change in the astigmatism, which almost in all the cases remains stable after after whenever you check. So there is inferior steepening, superior flattening, skewing, and such things which are known to everyone. So there is nothing great about the diagnostics. But post-refractive surgery is the thing which has caused so much of interest, because we started doing refractive surgery. We found that some of the patients will go into a situation where there is visual loss, and that is where corneal ectasia came into much more importance and has created a lot of interest in last, say, 10 to 15 years. So basically, post-refractive surgery is when the residual stromal bed is thick or the flap was thicker. And the most important fact is that there is preoperative signs of subclinical ectasia by tomography which were missed. And this is the most important factor which I feel is, should be taken into account. Sometimes it is impossible preoperatively to identify all patients at risk, and the facts that you have a situation where everything falls into normal, there is still ectasia post LASIK or post corneal refractive surgery. So the treatments were, sought, and finally, what is most commonly practiced in ectasia treatments is corneal collagen cross-linking. It reduces the risk of progressive ectasia in patients with keratoconus in early stages. That's very, very important. So we must treat all these cases as early as we are sure that they should be treated, and is very important tool in the management of ectasia after keratorefractive surgery. Definite etiology is unknown. 95% of patients do not show evidence of specific hereditary pattern, though there is a genetic issues, but hereditary pattern is not so kind of very constant. Pattern of inheritance is variable, and environmental factors are very, very important, and they include contact lens, chronic eye rubbing, and atopy of the eye. So in a normal cell, there is oxidative stress because of atopy or eye rubbing, and these produce the ROS compounds, which are eliminated by antioxidant enzymes and enzymes, and minimal and normal cell function is maintained. But in a keratoconus cell, these abnormal enzymes which are there, they are not very effective in removal of these ROS compounds, and then these continue to accumulate, and there is a T degradation. Also, there is damage of the and abnormal cell function along with the corneal thinning, and this leads to ectasia. So there are a couple of theories like connective tissue abnormality theory with connective tissue disorders, genetic theory, whereas where there is occasional association of trisomy 21, hormone theory because this is more manifestation in adolescence, and eye rubbing, which is very well known established fact as of now. There's so many common ocular conditions, but sometimes systemic diseases are also associated, like atopic dermatitis, Down syndrome, Ehlers-Danlos syndrome, and osteogenesis imperfecta, and the list you can see. So there's a lot of association with the systemic, and associated ocular disorders are retinitis pigmentosa, Leber's, congenital amaurosis, and blue sclera, and ROP, etc., where you find that all these patients have more possibility of developing ectasia or keratoconus in their life. So how to pick keratoconus in your OPD? There is photophobia, there is possibility of eye allergy. There are rubbers, there are a lot of eye rubbing they do because of the allergy. And also you'll find that there is frequent change of glasses. The more important fact is that frequently changing refraction, especially astigmatism, the scissor reflex, and Vogt stria, and photography is the major issue when you find that all these signs which are enumerated here are there. So the retinoscopy is one thing which catches it quickly, like water drop or scissors reflex, and loss of best corrected visual acuity, and thin central corneal pachymetry, and keratoconus. There is inferior cone with thinning at apex compared to a palliated marginal degeneration, which is again more or less ectatic disease, but it gives you a crab claw kind of appearance. So there is in a very advanced keratoconus, there is membrane, and there is development onset redness and pain, which is called acute eye drops, because of inhibition of aqueous intercorneal stroma, and aqueous intercorneal stroma causing it to swell. And can treat that, and most of the time it recovers wonderfully well. Pachymetry is very, very important. We can do it a slit lamp, ultrasonic, and also with the pentacam. Thinning in the inferior quadrant is mostly diagnostic of keratoconus, and less than 400 micron of keratoconal thickness is very, very significant. So we had Rabinowitz criteria for diagnosis of keratoconus, where the central corneal power more than 47, inferior minus superior IS value asymmetry of more than 1.2 diopter, astigmatism more than 1.5 diopter, and skewed radial axis of astigmatism more than 20 or 21 degrees, which was considered diagnostic in all cases. But then Amster-Krumish keratoconus accordance with the distribution area of ectasia is again very, very much more better, and stages as you can see here. So and then more advanced studies went into KISA percentage. It's the keratometry and IS values with the measure quantifying the regular and irregular astigmatism, and value of 100% of KISA percent is highly suggestive of keratoconus, and 60 to 100% is keratoconus suspect, and below it they are all normal. Then ABCD display is already discussed by Dr. Rajiv amply. So the treatment comes with the glasses or contact and intracorneal rings, deep anterior keratoplasty, and but I'll take the new collagen cross-linking in my talk. And this is the original method. Therapeutic corneal cross-linking was developed in Germany in 1998. The Dresden Protocol involves the use of UVA light and riboflavin to form bonds between collagen fibers. And exact mechanism, though, is unknown. It is believed that riboflavin causes the release of oxygen radicals that induces oxidation reaction to create new cross-linking bonds between collagen molecules. And the treatment is manual deepithelialization, riboflavin for 30 minutes. You have to observe clear fluorescence in the slit lamp in the antechamber, and then UV light for 30 minutes, continuously dropping riboflavin, and BSS to moisten the cornea, and it has to be controlled. So it's like this: beam aperture, 60 nanometer LED radiation with the UV light. Treatment plane is about 5 centimeters. This is how it should be falling on the cornea. This is how the continuous dropping of riboflavin is very important, along with BSS. And as you can hear, riboflavin acts as a shield, so there is nothing, no damage occurs at the level beyond 325 microns. And then the ultraviolet light, which is reaching below the cornea, is hardly of any significance. The important thing is that cross-linking kills keratocyte about 300 micron deep, and as you can see here, these regions after 6 months, and the cornea becomes normal. The thickness increases, and then after 6 months, there is reduced vanished corneal edema with regular endothelium. Now there are recent advances like 30-minute procedure plus 30 minutes exposure procedure, which takes about an hour. So there are accelerating and LASIK extra and customizing, and also riboflavin, which was initially prepared in dextran, is now prepared in BSS, and also transepithelial cross-linking. So what we need to do is about 90 milliwatt. So you can give a dose in 5 minutes if you have a exposure of 18 LEDs, and it is less time consuming and more comfortable. Dr. Kanellopoulos started LASIK extra, and after the flap and laser treatment, riboflavin is put on the surface, and then riboflavin is absorbed quickly, and very small exposure like a minute of 30 milliwatt gives you a good cross-linking in all these cases where there's a possibility that there's a weakness in the cornea and you feel that this patient can go into ectasia at a later point in time. And the LASIK extra is also important in all those cases of hyperopic correction, because regression is much less and stability is much better after hyperopic correction, otherwise which is not possible. Customize is when you remove epithelium in the center more than the periphery. The best thing is to remove the PTK so that the central thin epithelium is removed quickly, and periphery is still some epithelial cells are remaining, and then the effect of the cross-linking is more in the center, thereby giving a much better effect. And then in BSS or in water for flavin, the possibility that if there's a riboflavin water, and that can give you a good swelling of the cornea microns by putting 1 or 2 drops of and distilled water, and then you can do it thin cornea treatment with Dr. Rushad, and I'll give him this, and then transepithelial cross-linking has come, which is, there it causes less discomfort and very comfortable for patients, and is good for thinner corneas, but efficacy is much less. Iontophoresis, again, where the iontophoresis is used to get the riboflavin absorbed in the corneal cells, cornea and stroma, and it is very quick that way. Thank you very much.
Thank you, Dr. Bharti. And we'll take questions for you, Dr. Bharti, after we finish Rushad's talk, because it's on a similar topic.
Yeah.
Rushad Shroff is a very dynamic young eye surgeon who's completed his fellowship from the prestigious Narayan Nethralaya in Bangalore under Dr. Rohit Shetty and others. He heads the prestigious Shroff Eye Center in Delhi. And the young man is coming up really fast with lots of publications and awards already below his belt. So without further ado, Rushad to tell us about cross-linking in thin corneas.
Thank you, sir, for that very kind introduction. So I'm going to be talking on cross-linking in thin corneas. So we'll start with a case of a 27-year-old lady. It's a typical history that we get in a keratoconic patient. However, the thing to note in this particular patient was that the corneal thickness, when we looked at it by ultrasound pachymetry, was around 340 microns, which means it's a thin cornea. It's under the acceptable safety limit for corneal collagen cross-linking. She displayed the usual signs of Vogt-Stry, Munson sign, and prominent corneal nerves. And when we looked at the pentacam, we actually got a thinnest location pachymetry of around 329 microns. So when you get this kind of pachymetry and you that present like this, you're left with options of either epi-on cross-linking like the transepithelial procedure, or epi-off cross-linking like hypoosmolar, using hypoosmolar riboflavin, customized epithelial removal, or contact lens and lenticule-assisted procedures. So I'll go one by one across, come to what we actually did in this case. The transepithelial is enhanced drops every 2 minutes for 30 minutes. That's the Now, the enhanced drop basically means that these formulation have some form of either benzalkonium chloride or trometamol, something to loosen the epithelial cells, because the epithelium is a barrier which prevents riboflavin from soaking down into the corneal stroma. So these are the various different formulations that are there for transepithelial cross-linking, Vibex Extra being the one that we have experience with. After that, UVA exposure is conducted for 2 minutes. With an irradiance of 45 milliwatts and a surface dose of 7.2 joules per centimeter squared. Now, the issue with transepithelial cross-linking still is that the epithelium still barrier, and the cross-linking effect tends to be very leading to failure of cross-linking in these cases. In pediatric cases, but as of now, I am not using this technique anymore. When we come to the protocol for thin corneas, that's the hypoosmolar riboflavin. In this protocol, you're using 2 riboflavin. So initially, you use the isoosmolar drops every 3 minutes. You have to instill it after debridement, followed by doing an intrametry, and then after that, you start instilling the for every 20 seconds for 5 minutes. The pachymetry, if the cornea has swelled up greater than 400 microns, then go ahead with the usual Dresden protocol for doing the cross-linking procedure. So the basic difference in hypoosmolar, like Dr. Bharti mentioned as well, is that it's in physiological salt solution, whereas the isotonic riboflavin, nowadays we're using HPMC, but early on used to come with dextran. The hypoosmolar riboflavin does not contain any dextran in it. What are the drawbacks with hypoosmolar riboflavin technique? One, the surface time of this particular riboflavin is much less, so it stays on the surface for a shorter amount of time, leading to thinning of that barrier of riboflavin. The patchy cross-linking that can occur with this, its absorption coefficient is also lower than isotonic riboflavin, which leads to less safety and increased chances of endothelial damage. The next one that came into vogue was actually the contact lens assisted cross-linking. As we can see in this animation, the contact lens is placed after removing the epithelium and doing the debridement. It was described by Dr. Susan Jacob et al. And what basically happens in this is the drawback is that one, contact lenses can have UV filters. In this kind of cross-linking, you have to make sure the contact lens does not have a UV filter. The second thing is the oxygen permeability across the contact lens can be compromised. There can be a pooling of dye and buckling of the contact lens, which again leads to patchy cross-linking and not giving a uniform effect out. Following that, customized epithelial debridement techniques were also described, where you remove the epithelium in a grid pattern, or you leave the epithelium over the thinnest area and remove an annular disc around it. As you can see below, there are advanced ASOCT images from the bioptogen system, which actually show the permeation of riboflavin even below the area where we've left the epithelium intact. However, in this kind of cross-linking, again, you don't get consistent results because the permeation of the riboflavin may be affected by the intact epithelium. So following this, another thing which was very popularly described by Dr. Sachdev's group was the SMILE lenticule-assisted C3R. This had certain advantages because you're using a lenticule which you can match the amount of myopia with the patient who's actually getting the cross-linking done. The cornea, being the same constituent as the stroma, allows better permeation of riboflavin, and you get a more consistent effect of cross-linking in these patients. The drawback was that personally, I didn't have access to a SMILE machine, and in these refractive patients, you have to convince them to get a screening done for retroviral and HBsAg, which may be difficult to convince SMILE patients regarding. So in this that I described, we tried to do a lenticule-assisted procedure with a twist. Basically, we used a microkeratome to prepare a lenticule. This was a therapeutic-grade corneal tissue. What we did was we used the microkeratome with a 350 micron head. We got about 133 micron lenticule. After which we removed the epithelium, placed the lenticule over the cornea, and then did a 18 milliwatts for 5 minutes protocol. So the post-operative period, we did the treatment in the usual way. What I'd like to show is the results showed a good amount of flattening in the cone area on the axial map as well as the tangential map, as can be evidenced here. Densitometry did not show a significant amount of haze in this particular case, but we did get a demarcation line at around 212 microns, as is seen over here on the ASOCT image. This is yet another example of an advanced keratoconus where we use the same technique. And we have used this technique in about 32. So what we can see is a reasonably good reduction in the sphere, cylinder, and the mean refractive spherical equivalent, along with a good correction of the corrected distant visual acuity, as well as a good flattening in the K1, K2, and the Kmax. What was encouraging was that there was no change in the specular density, showing that the endothelial safety is good with this particular procedure. And again, the demarcation line was seen in about 20 eyes of patients. So the advantages, as I mentioned, is that the stroma allows better penetration of riboflavin, constructive use of therapeutic grade tissue, which may not be used. The screening of the tissue is already done, and in this particular case, you didn't have to invest in a SMILE machine. COVID times, and just now with the shortage of eye bank tissue, I particularly recommend that. What is field is changing rather than increasing the thickness, changing the fluence or the time. So what we can see in this graph, this has been proposed by Dr. Hafezi and Professor Sperl. Normal protocols, you would apply 9 milliwatts for 10 minutes. In this graph, however, on the x-axis is the and on the y-axis is the time for different cross-linking protocols. What you can see is that around 40 microns, you would use 22 minutes of the protocol and about 7.5 minutes of the 9 milliwatt protocol. Dr. Rohit and group have also created a calculator for this, and this is a link where you can feed in the value of the corneal thickness, and it tells you the amount of time that you need to apply the UV light for. For instance, if it's around 389 microns as seen here, a 3 milliwatt protocol would be applied for 28.3 minutes and a 9 milliwatt for about 9.5 minutes. So the take-home points of my talk, the thin cornea protocols are constantly evolving. Lenticule have shown good results in our hands, and fluence is basically a new area and is probably going to be a paradigm shift in this particular field of cross-linking thin corneas. So I'd just like to mention my acknowledgements. As always, Professor Shetty has guided me in all my work in keratoconus, so I'd like to acknowledge him and the others who've helped me with this presentation. These are dark times, but let's look forward to a brighter dawn. Thank you.
Thank you, Dr. Rushad. And that was a very nice and exhaustive presentation on the various choices we have if the cornea is thin. Dr. Bharti, there is one question to you from the audience. Why can't we do this cross-linking during pregnancy? Dr. Bharti?
So you're on mute.
Yeah, I'll unmute myself. That I have done. Can you hear me?
Yes.
So the issue is that keratoconus is, something which increases during the pregnancy. And yeah, can you hear me? Dr. Bhatt?
Yes, yes.
Yeah.
Yes, yes.
So it is mostly, even if it is a subclinical kind of disease, during the pregnancy it increases and evolves more, and there is always a little bit of thinning of cornea during pregnancy because of the hormonal changes. There is also thickening of the cornea in other cases compared to all these cases which are having a possibility of developing keratoconus. So that's another factor. And though in these cases where the lady is pregnant, I would suggest that the procedure should be done at the end of the pregnancy, maybe after first quarter of finishing the, of having a delivery. And then definitely before the start of the second pregnancy, even if there's document that there's some increase after the pregnancy, we can wait for a while and then advise. Yeah. So in the interest of the patient, and also the drugs which are used after the collagen cross-linking, they might be harmful for the baby. So there's two factors which will guide us that okay, let the pregnancy be over, and before the second pregnancy, we should do it as a prophylactic procedure.
Thank you, Dr. Bharti. Dr. Valla, I request you to introduce the next speaker.
Yeah, I'll invite Dr. Bhupesh to deliver his next talk, and he's going to talk on cataract surgery in patients of keratoconus. Dr. Bhupesh is a upcoming and dynamic ophthalmologist from Delhi. He's a very active member of DOS and UC, and he's done his fellowships from Narayan Netralaya and LV Prasad, and his areas of interest are corneal ectasia and lamellar corneal keratoplasty procedures. Over to Dr. Bhupesh for his talk.
Thank you, Bala sir. So I'll be sharing my presentation now. Okay. So good evening, everyone. So thank you, DOS, for the opportunity. So I'll be talking about cataract surgery in keratoconus eyes. Cataract surgery in keratoconus gives us a lot of challenges how to get the good result in these eyes. Have systematic solution to achieve good results. Talk about challenges in cataract surgery in these eyes. The first challenge is IOL power calculation in these patients. The main problem is with unreliable key reading in ectatic corneas, and there is a lack of dedicated biometric formulas for these eyes. IOL selection is another challenge, whether to go with monofocal IOLs, multifocal IOLs, toric or trifocal IOLs in these cases. Apart from these, surgical challenges are there, and despite of all these, there are unpredictable refractive outcomes. So we have to deal with that also. So coming to the IOL power calculation, the available biometric formulas require the axial length and keratometry as the minimum parameters. In keratoconic eyes, the keratometry is the most challenging parameter to measure, and there is a significant variation in key reading at the apex cone apex and from the remaining cornea. The K measurement in KC patients can be adversely affected by fixation difficulties and a displaced visual axis during measurement. So it's very difficult to see where the visual axis is there. And if you go with the corneal topography, the measurements are also more variable for steeper corneal curvature. So if you're dealing with the advanced keratoconus, you're not sure what is the apex. So, and the problem is especially in the patients with corneal irregularity and scarring. The irregularity of tear film reflex also makes it more difficult reliable and repeatable K values. The biometry in keratoconic eyes usually underestimates the IOL power and power Hence, inclination to a post-operative hyperopia is always there in these patients. There are various elevation-based topographic devices like Pentacam, Galilei that generates maps like True Net Power Map or True Power Maps or equivalent K rating maps. These maps are very useful in these eyes, and these also helps in better selection of K values needed for IOL power calculation. So we routinely use True Net Power from the Pentacam. Power maps or equivalent K rating maps. These maps are very useful in these eyes, and these also helps in better selection of K values needed for IOL power calculation. So we routinely use True Net Power from the Pentacam. It measures the refractive power of anterior and posterior cornea to estimate the corneal power within a specific corneal area. So this is a study published by Hashimi et al. Where they've compared the repeatability of various devices, Pentacam, OpScan, AlMaster, ISIS, and keratometer, and they found that the Pentacam device has the highest repeatability, whereas the OpScan 2 device has the lowest in mild to moderate keratoconus patients. It also shows that in group where the keratometry readings are more than 55, all 5 devices had low repeatability. So some of the groups recommend that it is better to consider using a standard K, that is 43.25 diopter for severe keratoconus, where you are not sure what is the K reading, and to use actual K for mild to moderate keratoconus in order to calculate IOL power. Coming to the biometry, the decentered apex of the cornea and keratoconus makes visual axis estimation very uncertain and challenging. Since the visual axis should be perfectly aligned for IOL calculation, the optical measurements are more superior to other methods due to better patient's fixation. So there is a disparity among authors regarding the best method for IOL calculation in patients with keratoconus, and the formulas that they take into consideration the axial length and other factors that help to predict effective lens position should be more accurate. The different formulas have been used in these eyes. The SRK2 and SRK-T works very well in mild cases of keratoconus, whereas the 4th generation formulas that are theoretically considered an improvement over the previous generation formulas are used in advanced cases. The Holiday 2, Aegis, and Barrett formulas works very well in these eyes. This is a literature published in Science Direct where they have reviewed all the IOL power calculation keratoconus literature, and they found that in mild to moderate cases, SRK2 works very well, although there is no consensus in the severe or moderate keratoconus group. Coming to the type of IOLs, first is the monofocal IOL. Monofocal IOL can be used in any grade of keratoconus, but if you have to choose toric IOL, for toric IOL, the appropriate patient selection is must. The patient counseling is very essential. What patient is going to achieve with that toric IOL in post-operative, that we have to explain him. It can be used in mild to moderate keratoconus, and the keratoconus has to be stable. These patients should have the good level of spectacle corrected visual acuity, then only we should go with toric IOL. If someone is having good vision with contact lenses, then we cannot be sure that that patient is going to get good vision with toric IOL also. And the patient should have regular astigmatism in the central 4 mm of the cornea. So these are the prerequisites for the toric IOL usage in keratoconus. The studies have shown the good results of toric IOL outcome in mild to moderate patients. There are various case reports coming up with use of trifocal or multifocal IOLs in keratoconus patients. Although these are very small case series, so still it's not conclusive that we should go for trifocal IOLs in cases of keratoconus or not. I think we need a larger study for that. Coming to the surgical tips, the planning the location of the incision should also consider the presence of corneal scarring, which is common in advanced keratoconus. So the main incision should be placed 90 degrees apart from the scar location so that it will not hamper during the surgical maneuver. Capsular steering is always better in these eyes because sometimes you get a lot of glare while operating, so it will help in the visualization. The keratoconus corneas are thinner and floppier, and therefore clear corneal wounds are more prone to leak after surgery and can induce significant astigmatism. So one option is that we should suture the corneal incision. The other option is that we should go for 3-step sclerocorneal incision, which reduces the risk of post-operative wound leak and also to induce less changes in corneal shape. Regarding the post-operative target refraction, what we should target, a low myopic post-operative refractive target is always preferable compared with hyperopic refractive outcome. So these are the essential points that we should always consider before going for the surgery of these patients. The age, whether you're going to operate young patient, middle-aged patient, or old-age patient for cataract surgery, whether the keratoconus is stable or unstable at the time of surgery, and what is the stage of keratoconus, whether it's mild, moderate, or severe. And we have to decide according to these points. And regarding the advanced keratoconus, where the scarring is severe and you're not going to achieve good vision with cataract surgery only, we need to go for combined procedures like triple procedure, PK with cataract surgery, or DLK with phaco plus monofocal IOLs. So in summary, determining the stage of keratoconus is very essential before planning the surgery. We should confirm the stability of the keratoconus. If we are not sure that the stable keratoconus is stable, we need to wait for 6 months. And if it is progressing, we have to go for cross-linking and then wait for the stability to achieve. Pentacam, optical biometers, and spectral microscopy is the essential test that we should go before planning these surgeries. The third generation or fourth generation power calculation formula works very well in these patients. The pre-operative patient counseling is must. We also have to optimize the surgical step that I've already discussed. The use of toric IL in mild to moderate cases can be done. We should avoid using multifocal or trifocal IOLs in these eyes, although the monofocal IOLs works very well in advanced cases. Thank you.
Thank you, Dr. Bhupesh. That was very nice because it's a very difficult thing to do and to get right. So it's always better to under-promise and over-deliver. Have a satisfied patient when you've told them that I'm not really 100% sure what I can do for you, but we'll try our best. So sometimes you get surprises no matter what advanced formula you do because the cornea fools you. We now move on to our star speaker, Dr. Rohit Shetty, among stars. He is doing excellent research work and bringing research from the lab to the bedside of patients. He's not only done a PhD himself, but he's motivated 3 of his fellows to go ahead and get PhDs in ophthalmology, which is extremely rare from Sweden. And every time he gives a talk, there is something new in his talk about, especially on a subject which he's passionate about, and that is keratoconus and its progression. So I'm over to Dr. Rohit Shetty to tell us about what we can do when waiting during COVID to modulate KC progression.
Sorry. Am I audible now?
Yes, perfectly.
Perfect. So thank you, sir. Thank you, Dr. Bharti, sir, the DOS, Ajanta Pharma, Dr. Balla, sir, Amrita ma'am, Rushad, and Bhupesh for this opportunity. My talk today is a little different. It gives a perspective of what do we do when we are during this COVID time, especially to modulate the progression of keratoconus. These are my financial interests. This is something very interesting. This is a hand-drawn picture by my lab scientist, Archana. And what she did was how an epithelial cells of a cornea has all the factors for the COVID. This is your COVID to bind onto this receptors and how it can cause the exact changes what happens in your nasal or oral mucosa. So this is the fear. If you're doing a cross-linking, the biggest fear for all of us is, at this point of time, I know we are jumping the gun. We are on a trigger happy impulse. It's always better to be safe and be overcautious than to say sorry, because it's not just you. It's you, your family, your staff, their families, a hell of a lot of people. If you are breaching something, see, this is how epithelial cells of a cornea is conducive for a COVID, and everything on cross-linking is on epithelial cells. Somebody said, "Oh, we use UV light," but here you're using UVA. UVC kills virus. So now, what do we do and when do we cross-link? And we don't know how far this is going to be. So when do you do cross-linking? First, let us look at all the high-risk characteristics of keratoconus. The age, the eye rubbing, the atopic disease, pregnancy. I think a lot of this has been covered by Dr. Bharati sir. Disease, pregnancy. I think a lot of this has been covered by Dr. Bharati sir, and in the beginning, Dr. Mukherjee has already covered. But in the next 3 months, if you have to do a cross-linking, what's your triaging system? Because, like I said, epithelial cells can harbor the virus in an asymptomatic patient also. We don't know. I may be completely wrong. I may be proven wrong. But at this point of time, let's assume it's there. So then it becomes much easier. So if you are seeing a 2 diopter of progression in 3 months, the age is 25 years and less. If the thickness is 430 and less, if you're planning a pregnancy, this comes under high risk, according to me, and you have to take a risk and offer the patient the cross-linking. Look into family history, the family scans. A high family history, if the mother has similar picture like this and all this father has something like this, that means that there is a high risk of progression. But the question keeps asking is, what do I do when I'm waiting? So I have 3 levels of ways in what you can do. One is the topical, one is the nutritional, and other modalities. These are my papers, part of my PhD of mine, and after that, this PhD was continued by Natasha. So there's a lot of stuff out here which says that inflammation is driving keratoconus. This is a very important word because with this comes the treatment. If it's not an inflammatory disease, if it's a genetic disease, then there's no way you know how to treat it. If you can pick this up, then you can treat it. If you can pick this up, you can treat it. Because all this, there are drugs for all of them available in the market. And that's why your definition is very important. We did this work to see what happens in the progressive versus stable. People who know me know that I work a lot on the tears, and this goes to the lab, and we do the test and all this stuff. And all these molecules which are necessary are all increasing. And what is interesting is all of them can be used as a treatment. All this can be treated with steroids, but steroids is not the way we would like to treat. So I would call this as like the movies of the Wild West. All of them are your wanted criminals. They're all there, and how do you treat them? So one of the things I always look at during this time, there is a huge amount of allergy. People are staying indoors. People are not coming out. People are using a lot of hand sanitizers. We'll have a lot of hand sanitizer-based aerosol issues, which were just getting published in the next issue of IGO, and high level of IgE, which causes all the changes in the keratoconus. So when you're waiting now, if the patient has a history of eye allergy, one is be very careful about what they do with hand sanitizer. Like apart from eye rubbing, which Gatinel keeps talking, I tell them, do not keep the sanitizers close to your face. Do not keep it under the fan. Do not keep it near the closed environment, because sanitizer-based allergy can trigger off all that's what can cause a keratoconus. And I'm and especially if you have a high IgE. So it's very important that you take care of it. That's the first thing. And take care of the IgE, get his blood test done. Because IgE can be treated, you can antihistaminic, mast cell stabilizers, and we have given an algorithm about more than 300, what you can do. If it's more than 300, that means there's a lot of stuff. It's difficult to get an immunologist opinion now because everything is under lockdown, but still avoidance of allergen is very important. And I'm seeing a lot of people with aerosol driven, especially abuse of a lot of the sanitizers, or you're working for long hours, and all this can help. And for them, I think mast cell stabilizers, or you can give anti-allergic tablets. But most important thing is these are acidic. So when you are giving a mast cell stabilizers, add it with a lubricant, because this has an acidic pH. So this itself can cause a change. And we have, this is all the published work of MMP9 on all the molecules which has. And one of the molecules which have worked extensively and which has a direct impact on all these molecules which cause progression. What are we interested is which to stop the progression. And one of the things which can actually do by reducing all of them is trehalose. And trehalose is one which is non-steroidal and still has a potential, because I'm very happy Dr. Bharti sir spoke before me. He gave a beautiful algorithm of reactive oxygen species and how they accumulate. What happens is when they accumulate, it's like your housekeeping is not working and all of them get accumulated. This actually removes that ROS and all the other factors. So that's why it is very important, and this can block a lot of changes. So this is what we do. If a patient is allergic, steroid for a short time, use cyclosporin. Cyclosporin is very good because cyclosporin acts exactly on the MMP9 and IL-2 and IL-4 pathways. And if the patient is non-allergic, then you can probably give him an for me, the drug of choice for all the keratoconus patients is trehalose, because it does what I'm looking for. The second one is people are living indoors. There are a lot of people indoors, and there is a lot of issues with the sunshine vitamin. A very interesting paper recently which came, which is very useful for all of us, is people who when they did a modeling of all the people who had very bad outcome of COVID, they found that one of the most important factor is low vitamin D. It's an immunomodulator all over the world, even for the COVID. So people who are dying or people who are in ICU, most of them had a low vitamin D of less than 10. And this is coming as a major factor. And this is what happens, it again has this bunch of molecules, the MMPs, IL-10s, and all these molecules, which also has a progression, which can cross progression of keratoconus. So it also depends on your vitamin D receptors. It's just not the vitamin D in your blood. And this shows that the vitamin D receptors are lower in keratoconus, which means that you need vitamin D for the stability and halting the progression of keratoconus. So the light, there's also a very nice study about people exposing themselves to 2 hours sunlight has a very strong chance of stability. And I've written all this here. It's an immunomodulator, brings in, it all depends on the vitamin D receptors. If it's lower, go to a physician and get yourself intramuscular dose. I wait for the physician to titrate the dose, because the hypervitaminosis can cause renal stones. And this is how it manages the ocular inflammation, because now a lot of them are indoors. Nobody's coming out. There's hardly any exposure. I'm sure lots of them would have a very low vitamin D and vitamin D receptors in them. Copper and zinc, as nutraceuticals, has a huge impact in how the collagen synthesis. This is important. The collagen is like this, and they're all tightly wound by the enzymes. What I'm putting as a circle is an enzyme, and these enzymes are lysyl oxidases. And what happens is these are zinc-based. So zinc-based and copper-based, if you have any of your composition here, is extremely good when you're looking at the collagen. So if you're prescribing a nutraceuticals, it's a vitamin D, zinc, and copper. These are the most ingredients, because the one which holds the collagen is lysyl oxidase, and that's what really helps. This is most important part. All of us have used thermal pulsation therapies. There are lippy flows and iLight and EI. I have used this even before the COVID came for people who are having a lot of eye rubbing, a lot of irritation. The reason I've used this is I did a study about I go all from my cell biology angle. All my work is from how I understand a body and then how I can use it on my treatment. So I go back and forth. So all the molecules here, which you mentioned, are the ones which also have a very important role in progression. That means the keratoconus progresses because of these molecules, all that wanted stuff here. And what is interesting here is After I do the lipid flow, all these molecules which is in red has come reduced. And that is what is very important for me is using, let's say, lipid flow or EI or iLight or one of these cousins of these light-based therapies. What we are trying to do is we are actually blocking a lot of them would otherwise cause the keratoconus progression. So if you all have access to it, I think it's a good time to use it. These are non-invasive. You can buy time, and you can see that this is an highlight also. You can see how it's changed. I have studied more than 10,000 of these molecules, but what we have put here is the one which causes progression. So I underline this way, and if you can stop it, then you can block it. So this is what I feel at this point of time. If you have it, please use it. I'll give you the example: 28-year-old males, no allergy, lot of eye rubbing, lot of irritation, and he had a moderate risk of progression. So what I did was I did this lipid flow for him. I've also experienced with iLight and EI, and you can see that his keratoconus has stabilized. And look at this. It's a 1.2 diopter of reduction. That means when the inflammation goes off, the eye can actually get better. And this is a classic picture of what can happen if you're using it. So don't just use it in a box that, okay, if it only dry eye, I'm going to use it. Think out of the box. I think COVID is the time where all of us have to think out of the box. And this is what I do when a severe allergy, vitamin D, treat this. If it's a low allergy, just artificial tears. You can combine, if there's a medium KC, then you can combine with an artificial tears. Like I said, my drug of choice is trehalose base. And if it's a severe and you don't want to do anything now, think of a thermal pulsation along with cyclosporine. So use your combination well. I think then you can buy time, the patient is comfortable, and you are ready for your cross-linking in a few months down the lane. And this is the whole summary of what I've said. Just one more slide about if you are doing cross-linking. This is a paper I'm working on. Hopefully it should be ready by tomorrow. I'm going to submit to one of the journals about what should you do when you go into clinic, when you operate, whether it's cataract, refractive surgery. This is the picture which Archana has made. And I have 2 drugs here, which is eye drops. So I have 2 eye drops. One is chloroquine, other one is trehalose. Both of them I've seen in whatever I sit in the green and blue, shows exactly where it's acting. So chloroquine acts on the endocytosis of the virus, and the trehalose act on the cathepsin pathway, which it goes into the cell. It also induces interferon alpha. So what I'm trying to say is, if you're working in your OT and you know that you're exposed to aerosols and you want to be very safe, I use one of them. I use, if my OT is more than 1 or 2 hours, I use chloroquine on myself so that I know that this pathway here is blocked. It does not kill the virus, but it protects it from actually getting into your cell. That means it's like a PPE from the ocular surface. Like I said, at this point of time, disclaimer is in hypothetical based. Everything in COVID is hypothesis. Over time, I think we'll know what is true and what works and what does not. I thank Dr. Bharti and the DOS for this opportunity and my talk here.
Thank you, Rohit. Before you leave, Rohit, a couple of questions. One is, in view of what you said, would you change the definition of keratoconus forever to include that it is an inflammatory and degenerative disorder?
It is now, I think, most of the, and if you really look at the papers published before 2000, most of them would define it as a non-inflammatory. Now I think everybody talks about it as an inflammatory one. Which comes first, the eye rubbing comes or the inflammation comes one? That is going to be the debate which is going to last a lifetime. But,
and Rohit, would we therefore shift because of this COVID being in the epithelium that you from now on?
I would see anything which you touch your epithelium is always going to be extremely difficult, because minute you touch your epithelium, if I can just show this slide. Actually, I don't know whether you're seeing this. Yes. I'll just go back. I'm sorry for this. Because it's just blocked in the epithelium, it is very, very important that how you discard and what you do with the epithelium has to be very carefully looked at. You're right. If I'm completely on laser, I zap them up, but you also have to understand that the temperature, what you're creating on the surface is just 42 degrees with the laser, and this virus can survive up to 55 degrees. So even if you are zapping them with your laser, it may not kill them. That is what I'm trying to say. But when you're using alcohol or you're debriding manually, you have a very potential high chance because of fluid. The aerosols can go up to around 3 to 4 centimeters to 8 centimeters around your space. And that is the space where you are sitting. There's a space where the microscope, your laser machine is there. So laser in that way would be much better because you're not creating that aerosol. I mean, this again an hypothesis. But with this picture, what I put here, we have to understand that there is a huge risk of epithelium being floating around.
Okay, thank you, Rohit. And I request Dr. Bhalla to introduce the next speaker.
Yes, sir. So just wanted to ask one question to Dr. Rohit. Like you said, putting chloroquine drops in surgeons' eyes may be, I think that can be sort of protective thing to prevent binding of the virus. But can we do that same thing in the patient's eye also? Because initially you have done betadine cleaning and disinfection, but later on as the surgery courses around for 15 to 20 minutes, then I think that assumption can be carried forward to prevent the binding of the viral RNA to the patient's epithelium also, corneal epithelium.
Sir, what happens is when you use these drops, it only protects it from getting in the cell. The patient is already inside the cell. It's not going to do anything on that cell. But you are assuming that you are healthy and you don't have a virus and it's coming from the patient. So this is just like using your protective gear, assuming that he is infected and you are not. And so at this point of time, I'm not really sure about what it can do to the patient. But of course, you can try it. I have done it when I have to do any epithelial-based procedures. I have tried it. Chloroquine is a preferred one, but of course, Trehalose is also a simpler one because it's just a lubricant and we have used it. And both of them work more or less on the same pathway of a catapsin-based pathway, which allows the virus to enter. So, I mean, at this point of time, I'm just giving hypothesis. I may be completely wrong, but like I said, a good hypothesis is better than nothing.
Right, sir. Now I'll introduce the next speaker, Dr. Ritika Sachdev. She's going to give her talk on intracorneal ring segments in ectasia. Dr. Ritika Sachdev is a young and dynamic ophthalmologist from Delhi. And I think she hardly needs any introduction. She has done her post-graduation from Maulana Azad Medical College, Delhi, and did senior residency from RP Center, two of the Apex institutes. And she's director of Center for Sight Group of Hospitals and has interest in cornea keratorefractive surgery. Over to Dr. Ritika for her talk.
Thank you, sir, for your kind introduction. And I'd like to thank Dr. Bharti, Bhupesh, and the DOS for this kind invitation. I'll be talking about intracorneal ring implantation for patients with keratoconus. Now, this is an important adjunct to treating keratoconus because it is an additive technology. That basically means you're adding to the cornea and not removing from it. And in doing so, you're going to normalize the structure and therefore the function in terms of vision. These are basically intracorneal ring segments are made of PMMA and they're tiny crescents, and they were described as early as 2001 by Collin, and they were to be used to reduce myopia. However, laser refractive surgery took over, and now intracorneal ring segments find use in weaker corneas like keratoconus and post-LASIK ectasia. The two most commonly used intracorneal ring segments are the intacs and the Ferrera rings. The intacs are classically hexagonal in cross-section and implanted between the 7 to 8 mm zone. The SK segment is more ellipsoidal and implanted closer to the pupil, 6 to 7 mm. The Ferrara rings are further closer to the pupil and therefore have a triangular cross section. Now remember, whatever segment you implant, the closer you get to the pupil, the more flattening you may be able to achieve, but you also have the risk of unwanted visual side effects. Irrespective of the segment that you use, this is how it works. When you implant an intracorneal ring segment, it acts as a spacer device. So this spacer device, as you can see in the figure, flattens the central portion of the cornea. This is the arc shortening model that will reduce myopia and in case of keratoconus also normalize the shape. What are the indications for its use? We classically use it in patients who are contact lens intolerant and have central clear corneas. The area where the intact segment or the ICRS segment has to be implanted should have a thickness of 450 microns. Remember, this is usually not the central area, it's a paracentral area, and you are able to get this thickness in patients with keratoconus in the peripheral areas, which is where the ICRS is implanted. I do not prefer to do ICRS in patients who have a very good vision like 6.6 or 6.9 with glasses because there are reports that you can have a drop in BCVA if the vision that you're starting out with is very good. And if the patient is very mild, you should just take him up for plain cross-linking of progression. Now, how do you evaluate a patient? We've already heard of the evaluation of keratoconus, and a topography and a good refraction is basically what we need. If the cone is central or that you can see on topography, which will normally manifest as a more of a spherical error, you will need symmetric segments because you're just wanting to flatten a centralized cone. If, however, you are dealing with a decentralized cone, you would need asymmetric segments because you would have a thicker segment which pushes the cone and regularizes it, and a thinner supporting segment. So really, it is the position or the centralization of the cone which determines if you're using segments which are symmetric or asymmetric. The extent of the bulge, that is the keratometry or the refraction, will define the thickness of the segment that you use. So the thicker the segment, the more will be the flattening. You also need to obviously plan the incision, which is usually on the steep axis. The steep axis is determined by both the refraction and the topography. Remember, you're trying to treat a function, that is, you're trying to treat the vision and the refraction, and therefore the axis of the refraction overrules the axis of the topography if the refraction is reasonably accurate. You must leave about 100 microns behind the ICRS and try and suture the incision because it only enhances the effect of the ICRS. The ICRS can be implanted manually. However, with the femto laser, this technique has become more popular because complications have reduced significantly. This is the tunnel for the ICRS being created by the femto laser, and this is the deep cut which will allow you to implant the ICRS. Like with all femto lasers, there are some tissue bridges that you need to cleave. You first go vertical and then you move into the tunnel and you create the clearance for the passage, and then you grab the ICRS segment. Remember, you have to go vertically first and then simply wheel it into the tunnel. There will be some resistance that you face. The distal end must be pushed into the incision to avoid extrusion at a later date. Now, this is a case example. This is a 22-year-old female with keratoconus. See the refraction. It is higher spherical, a higher cylinder, lower spherical. So you may think that this patient, because of a higher cylindrical power, requires asymmetric segments, but we must transpose and have the cylindrical power in the positive connotation. So when we transpose, it is the spherical which is higher than the cylinder. Also, the topography shows that the area of maximum elevation on the posterior float is within the 5 mm zone, and this patient will go for symmetric segments with the axis of the incision planned on the steep axis 120 degrees. This is the post-operative picture and the comparison map showing a flattening. This is the patient post CXL. You see when you transpose, the patient has a higher cylinder and the topography really shows a decentralized cone, and this patient can go in with either a single segment or an asymmetric segment implantation. This is the post-operative difference. A debate is that whether you want to do cross-linking before or after intacts. However, we normally do it simultaneously. That is because the increased biomechanical rigidity of C3R is there, and when you are doing it with Intacs, you're actually freezing a better position and flattened cone. Also, the riboflavin penetrates very well into the Intacs channel, and this cross-linking along the channels actually enhances the effect of Intacs. So, for the effect and for the convenience both, it is a simultaneous C3R and ICRS that we follow. This is another patient with high K values, and you can use the SK segment, which is implanted closer to the pupil, and it's thicker, so it will give you a greater flattening effect. It is in post-classic ectasia that ICRS are very useful, and because these are classically more inferior and decentralized bulges, you can go in for a single segment. Also note that cross-linking is usually not as effective in post-classic ectasia as it is in keratoconus, and therefore Intacs is a very useful adjunct. This is really a patient of mine which made me believe more in Intacs and over plain cross-linking. And this is a paper which explains what happens. This is a paper by Dr. Cynthia Roberts, which basically says that ectasia is basically a vicious circle. Where you have a thinner cornea, there'll be more biomechanical stress, and that thinner cornea will become more ectatic. And as it becomes ectatic, it becomes thinner, and therefore you have a vicious circle of biomechanical stress propagating the ectasia. What the ICRS segment does is that it basically redistributes the biomechanical stress and in a way can bring a stoppage to the progression, if not completely, at least as an adjunct to C3R, and also help you get better vision. This is a patient of mine who came with post-classic ectasia. You see here that there is a bulge in the center. She was operated elsewhere. This is what happened as her cross-linking. She had a progression during her pregnancy, and we had cross-linked her. This is her picture post cross-linking, and this is her progression in her second pregnancy. So despite a cross-linked cornea, she has progressed both in the first and the second pregnancy. She was cross-linked between the first and second pregnancy. This is the other eye where we felt that the central nipple protrusion was quite significant, vision was very bad, and so therefore she went in for ICRS plus cross-linking. This is her position post the ICRS and cross-linking, and this is how she behaved in her second pregnancy. So the eye with ICRS plus cross-linking remained stable because this possibly had a much greater role together, synergistic, and also because the case was that of post-classic ectasia. Now, ICRS also comes with its own set of complications. This is a case where we accidentally perforated the cornea because this was a post-cross-linking patient. So we had to change certain settings in our laser. And inadvertently, we created a false passage, but you can easily remove the ICRS from the cornea. And the cornea is an amazing tissue, bounces back, and this is what the patient looks like with no loss of BCVA. There can be white cell reaction or calcium and deposits around the ICRS. The white cell reaction usually responds well to steroids. You need to optimize the ocular surface for all procedures prior to, for example, cross-linking or ICRS, because the allergic eye disease or the inflammation will cause not only keratoconus to progress, it will also cause unfavorable outcomes for the procedures that you do. This is a patient where the reaction was so excessive that there was a melt that was noted. In such a case, you see that the ICRS segment is exposed and must be removed. However, because it was removed a few years after the procedure, the scarring around the segment and the fact that it had been there for 2 years, the flattening effect of the ICRS actually did not reverse. We obviously have improvements that are happening, and now instead of PMMA, there are flexible acrylic polymers that are being studied and being used to create ICRS. The BioRing has now been launched, wherein the base is more tilted and the apex is rounded to remove the side effects of endothelial pressure or stromal decompression and the deposits around the ICRS. So all in all, ICRS are a safe and predictable option for reducing the refractive error and also possibly an adjunctive role in preventing progression in keratoconus. Thank you for your attention.
Thank you, Ritika, for an excellent overview of ICRS and ring segments. We are blessed to have with us Dr. Chitra Ramamurthy from who is currently the chairman of the academic and research committee of the AIOS. She also has a wealth of experience in not only ICRS but in everything to do with keratorefractive surgery. And I would invite her to answer a couple of questions which were asked by the listeners on Ritika's talk. One is, how expensive are corneal ring segments? And Dr. Chitra, in your opinion, have you had to remove these? Dr. Ritika did show some pictures of how easy the removal was. What is your experience, Dr. Chitra?
Yeah. First and foremost, my thanks to Dr. Bharti and DOS for inviting me to be a panelist here. Regards your question, I would say it roughly costs about 30,000 per ring. That is, if I'm two symmetric rings, then it comes to about 60,000. And I have had an opportunity to couple of opportunities where I've removed these intact segments. So the common thing we should look at when the need comes up is if it's a loose suture, and if there's a loose suture, there tends to be local epithelial breakdown. It could progress to stromal melt, and that could be one reason why there is an extrusion of these intact segments, besides being superficially placed or overriding of intacts, which can again be a causative factor for epithelial breakdown. So whenever we see a loose suture, we should deal with it right away so that you do not have to end up with the intact segment extrusion. But having said that, as Ritika said, that it does, if you have having to remove it much later on, some amount of flattening remains actually. And it is not that the whole thing gets annulled just because you have removed a segment because of extrusion of these segments.
Dr. Chitra, may I request you also to help us by introducing the next speaker, Dr. Namrata Sharma?
Introducing Namrata Sharma. I think at this point of time, she is the most dynamic woman in ophthalmology, and many of us would like to emulate her. And the very recent guidelines which she has come up with, the kind of hard work she has put in to bring it up, which is literally a book to read for all of us, is just one more reflection of the amazing hard work and skill of Namrata Sharma. And she's, as we all know, she's presently the Honorary General Secretary of AIOS and is also the Regional Secretary of Asia Pacific Academy of Ophthalmology. She's a professor of ophthalmology at All India Institute, Delhi, and has done her post-graduation there and also a fellowship for Moorfields Eye Hospital, London. It would be so inadequate when I'm suddenly asked to introduce Namrata, but I wish her all the best in her career, doing more and more good to ophthalmologists of our country at large.
Thank you so much.
If I may add, she is also Secretary of Delhi Ophthalmological Society, and whose flag this meeting is going on. Thank you, Dr. Namrata.
Thank you so much for that kind introduction, Chitra. And thank you, everybody, again for being here at the platform of DOS and doing such a great webinar and gracing the Delhi Ophthalmological Society platform. And we would like to particularly thank Dr. Bharti sir, whom I have the highest regard, and I've also worked with him earlier when he was the DOS president, and it was just a pleasure to work with him. Dr. Mahajan, who is the current president of DOS, who's also been very, very helpful. And I would also like to thank Dr. Bhupesh for organizing this, and Dr. Rushad Shroff for helping with this webinar. So with this, I will come to my talk, which is transplants in keratoconus. So I want to share the screen. So can somebody just remove the... So I'll be talking to you about the transplant options in cases of keratoconus. And you can have primary keratoconus or you can have ectasias due to various causes, which could again be primary or could be iatrogenic after refractive surgery, or even after intacts, or even after penetrating keratoplasty. And the surgery which you are going to do would be determined by the ectasia, by the presence or absence of cornealoplasty. And what has been classically described in patients with advanced keratoconus is also Bowman layer transplantation, which was described by Mallis, where Bowman's layer is taken and is transplanted intrastomally, so that you cause splinting of the cornea, and that causes flattening of the cornea. The results were pretty good, but they have not been reproduced by various authors in various studies. And until we have a long-term follow-up, it is difficult to say how these eyes will fare. Now, apart from this, when there are advanced cases, then one can do either anterior lamellar keratoplasty. So if the moderate to advanced cases are there with corneal thickness less than 380 microns and contact lens intolerant, then you can do manual lamellar keratoplasty or automated lamellar therapeutic keratoplasty. But if there are advanced cases, corneal thickness less than 380 microns, contact lens intolerant, then one can do DALK or deep anterior lamellar keratoplasty using various techniques. And of course, when there's corneal scarring or cases of healed eye drops, you can do penetrating keratoplasty. But nowadays, in some of the cases of healed eye drops, also we are doing deep anterior lamellar keratoplasty because it's an extraocular procedure. This is just to show how automated lamellar therapeutic keratoplasty is done. So the cornea is taken, it is split anteriorly and posteriorly. So anterior 350 microns of the corneal tissue is taken, and this is a keratoconic cornea on which the microkeratome is placed. And again, 250 microns of the cornea is removed from here. And this cornea, which is 350 microns, is then taken and is placed onto the recipient bed and is sutured with 10-0 monofilament nylon sutures. The sutures have to be tight so that it causes the flattening of the cornea. Then another technique which has been described and is the gold standard is the big bubble deep anterior lamellar keratoplasty, and this is that technique. So air bubble is instilled into the supradesmate membrane compartment after doing keratectomy, and on the intraopposite microscope you can see that the descemet membrane has fallen back. This is an inverted image, but as you give a nick in the overlying stromal layers, notice how in a live show the descemet membrane marches towards the overlying stromal layers as the air is egressing out from here. So you know that you are in the right compartment. And subsequently, when you inject viscoelastic inside, the descemet membrane falls back, and you are still extraocular because you've not perforated the descemet membrane. And then subsequently, these overlying stromal layers are cut with the help of the Vanna scissors. And then this is a bare descemet membrane which is staring at you and you know, and which means that you are extraocular. And this is a full thickness donor cornea which is taken and then sutured with 10-0 monofilament nylon sutures. So sometimes you can have a type 2 big bubble such as in this. So type 2 big bubble is the one which will come from the periphery and not from the keratectomy edge. And you can notice that it has come right up till here. So we are stopping short up till here, not letting it go beyond the keratectomy side, because then otherwise the case would become very difficult. Now this is followed by the paracentesis that is done, which is classically done. And then notice how the bubble will move as you give a nick in the overlying stromal layers. And this descemet membrane will move very fast, unlike the descemet membrane previously when you have a type 1 big bubble where it moves very slowly. Here it moves in a split of a second, and then again one can do the case similarly by putting viscoelastic in the supradescemet membrane compartment. These are some of the cases which do very well. Now, with the big bubble technique, the chances of perforation range between 4 to 11% or 13%. And so that is why options have come up so that the chances of perforation are not there. Now, this is a healed eye drops case, and in this case, again, we've attempted IOCT guided deep anterior lamellar keratoplasty. Notice that there is a scar which is present here, and trephination is being done. The good thing is that the scar is paracentral, so the nick is given in the overlying stromal layers, and because this intraopposite microscope is there, you can actually see where your scar is, and just go above the scar, as you come near the area of the scar, the dissection can be quite controlled because you're doing it manually. And as we come to this area where the scar was present, we go a shade little bit anteriorly so that that little bit of stroma acts like a valve there and it doesn't allow it to perforate. So as a result of which the case which was here now looks like this. And so you are still extraocular and 52 microns of the stroma in the Descemet's membrane remains, which is quite acceptable. Then you have tuck-in lamellar keratoplasty for cases which are large cones, pellucid marginal degeneration, keratoclobus, or post-PK keratoconus. And in this case, the advantage is that you have a partial thickness flange, which is there all around, along with the central cornea, which is there from which the Descemet's membrane has been removed. Or in case of pellucid marginal degeneration, you can just have this little bit of flange, which is there because you have to address the area of the thinned out cornea. And this is a technique which was
two-stage lamellar dissection.
This is a technique which was described by Professor Vajpayee long time ago, but this is a technique which is so relevant even today. And this was something which was done without using a femtosecond laser, and now people do the similar thing using a femtosecond laser. So after creating the pocket, which is all around, after doing a lamellar dissection, the peripheral part of the flange is removed. AC paracentesis is then done, and this bit of the cornea is then taken, and this is placed in such a way that the flange is tucked 360 degrees all around with the sutures. And when the sutures are out, then you can hardly make out that any keratoplasty was done there. Now this is the same thing to show in pellucid marginal degeneration because the thinning is inferiorly, so the flange is only kept inferiorly. Of course, the suturing is a little bit difficult. You have to come out from this area and then from the flange and then go into the pocket. So from the edge of the graft, then into the flange and then into the pocket right up till the limbus, so that you can anchor the tissue there and the flange that is there can be inside the pocket that was previously created. This is just to show the post-op picture. And of course, in cases which have scarring like this, you have to do a penetrating keratoplasty. And this is a simple procedure which actually all of us know so well for the last so many years. And so full thickness keratoplasty now here is being done with the Hesberg-Barron suction trifine, the viscoelastic which is placed, followed by the full thickness donor cornea with good endothelium and with 10-0 monofilament nylon sutures which are then sutured. And this technique is something which we are working at and have already standardized it. This is the bioengineered cornea, so a femtosecond laser is being used here to create a pocket, and subsequently this pocket is opened. And after opening this pocket, you have a synthetic cornea which is made of the by recombinant technology, and pretty much looks like a contact lens, but it is a little stiffer than that. And this is folded just as we used to fold our old intraocular lenses on a forceps. This is then placed inside, and this is then unfolded inside the pocket and left sutureless after placing a bandage contact lens. We've started even cross-linking it after putting this inside. So this is something, especially when you have paucity of good quality donor material, this is something to look forward to. And mostly in the corona times when we are not going to be having too many tissues. This is a book we've authored on deep anterior lamellar keratoplasty, different strokes. And thank you very much for your kind attention.
Thank you, Dr. Namrata. She is an authority on the subject that she speaks in, and which is true of most subjects that she speaks in anything to do with the cornea. And I request Dr. Balla to introduce the next and hopefully the last speaker.
I think, sir, it's my privilege to introduce Dr. Quresh Muscati. And Dr. Quresh Muscati is one of the pioneers of Indian ophthalmology, sir. He's been past president of All India Ophthalmic Society, past president of Bombay Ophthalmic Association, and also president of Maharashtra Ophthalmic Society. Currently, he is president of International Society for Manual Small Incision Cataract Surgery and also president of Corneal Society of India. He also happens to be chairman of FBS AIUS in the current term, sir. Over to Dr. Paresh Maskati, and we are all very great fan of not only your, sir, quizzing, we are also, we always sit down to listen to your stand-up comedy, sir, for your talk.
Thank you,
Good evening,
Dr. Balla. Dr.
Good evening, Dr.
Mahajan,
Maskati.
yes.
Yeah, yes, you
evening.
don't need an introduction because you are so famous and so loyal ophthalmologist of India. I know you from the days when you started with the artificial cornea with tooth and everything, that camera.
Thank you.
Yeah, that was the days. So
Thank
please
you.
continue with your talk. Thank you very
Thank
much.
you. So as I said earlier, the best part about my talk is, as I've shown you with the arrow, this is indeed the last speaker. Dry eye disease is treated with a wide range of treatment options. We have lubricants, secretagogues, anti-inflammatory therapy, surgeries, moist chamber goggles. But time being short, we'll talk only about the lubricants, which are the mainstay of dry eye disease. Everyone from the chemist to the family physician to the general ophthalmologist to the cornea specialist, everyone prescribes artificial tears because they're the most affordable and the immediate and least invasive form of relief. And as we grow older, you know, the 4 stages in life, the 4 bottles, the milk bottle, the Coke bottle, the beer bottle, the saline bottle, and now there is just the 5th bottle, which is the eye drops, which almost all of us seem to require. So artificial tears are various derivatives, some like the cellulose derivatives, the methyl cellulose, hydroxypropyl methyl cellulose, carboxymethyl cellulose. These are all cousins of each other. Then there are synthetic polymers like PVA and PVP. We can't pronounce them, so we use their abbreviations. And there is HP guar, hydroxypropyl guar. However, the trend nowadays is to see if we can combine different drugs and see whether we can get an additive effect to break the dry eye cycle. So one such promising, recently commercialized combination is that of sodium hyaluronate. I jump over that, so I call it HA from now on, or SH, sodium hyaluronate or hyaluronic acid, and the natural disaccharide trehalose, which Dr. Rohit Shetty spoke about in glowing terms for keratoconus. So since this is a talk on keratoconus, I thought I would talk about a drug which is HA with trehalose and some osmoprotectants, indeed a 3-in-1 solution for dry eye. So as we are aware of HA, which is a natural component of tears, there is some amount of HA in our tears, and it does display an excellent effect by itself in dry eye treatment by both its biophysical properties and biochemical properties, both as well. The biophysical are high water retention, right viscosity, and being mucoadhesive and mucomimetic. And there is biomechanical properties, which is its peculiar binding to CD44 and free radical scavenging, which we'll learn more about as we go. So first, the biophysical properties. It has a high water retention, which is long lasting. And how does it do this? Because HA has this peculiar ability of trapping 1,000 times its weight in water. What it does, it forms a water bridge between the amine and carboxyl groups, as you can see in the chemical slide, which none of you understand. And therefore, by this water bridge which is formed, it's able to trap its 1,000 times its weight in water, which is a very good quality to have. Besides which, it is both mucoadhesive and mucomimetic. Mucomimetic means it mimics mucins. As you can see, some of our Asian colleagues mimic each other. They all look alike. Similarly, HA looks alike with some of the mucus that we have in our tears, and it is mucoadhesive also. So it adheres to the ocular surface for a fairly long time. And it has, as I said, CD44. We'll talk about that later. But it's proved that it improves the TBUT gradually over 8 weeks. So just by itself, it's able to improve the breakup time. And the unique property, it's like if you imagine a wire which is coiled up amongst, you take just an electric wire, colored electric wire, and roll it up into a ball type of thing. And then you can unroll it into a string again. Exactly like this happens when we blink. So when we blink, during the blinks, the SH molecules align with each other, resulting in like a single wire, as it were. So it sits very well on the surface. And in between blinks, it forms a tangle meshwork coming onto one side and therefore stays in the eye for a longer time. So it changes its physical characteristic during blinks and in between blinks. Finally, I was leading up to this teaser trailer about CD44. What exactly is this CD44 and why is it important? CD44 is a glycoprotein which is encoded on the short arm of a chromosome. It's an adhesion molecule, which is a pokey type of thing which pokes out from the cells whenever the cell is disturbed. So whenever there is a dry eye, the inflammation occurs, and these CD44, like tiny pokey arrows, poke out, or like cactus in a desert. They poke out of the cells and therefore cause more irritation in the eye. So what does this HA do? The HA goes and binds to the CD44, sort of soothes the cactus so that if there is the tears flowing, they can flow over this, and the surface is not so rough. So if you imagine the cactus in the desert, and you imagine this, the more the CD44 which is released by the cells, as inflammation increases and the dryness increases, more CD44 is released like needles of a cactus, and the HA goes and binds to this. So the more which is released, even more HA goes and binds to this, and therefore soothes the surface, something which no other molecule is able to do. So there is huge advantage of the HA binding to CD44, as can be seen in this. It changes the pattern of the cells from 100% pathological to almost all of them becoming physiological, and the staining score improves tremendously. So HA adapts across the severity levels of dry eye. In the initial phases, just because it holds the water so much, it relieves the symptoms very well. Remember, I told you 1,000 times its weight in water. And in moderate dry eyes, the mucoadhesive property, so it acts like a mucin film over the cornea and the ocular surface, preventing further damage. And as the severity increases, its affinity to CD44 helps it to improve the dry eye status. Now, Trehalose, Dr. Rohit Shetty introduced the subject. It's again widely distributed through the biological world. It's a naturally occurring disaccharide, and it's found in plants, bacteria, everywhere, and including in our eyes. It's osmoprotective. We'll talk about the advantages of osmoprotection later. But Trehalose is uniquely bioprotective, and it's the only molecule which prevents premature cell death or apoptosis of our ocular surface in spite of being desiccated or severely dry conditions. So it's bioprotective. It protects against hypoxia and anoxia. So in a dry eye patient, there's a lot of hypoxia, anoxia, inflammation induced also. So it reduces the apoptosis induced cell death better than any molecule so far discovered. So it not only directly protects the cells from desiccation, but also by preserving the cell membrane from deactivation or denaturation during desiccation, it also indirectly protects the cells from death by desiccation. So both directly and indirectly, desiccation is just a fancy word for dryness. So it prevents the cells from dying in spite of the trigger factor of extreme dryness. So Trehalose would therefore produce a new way of treatment of dry eye. And let us see whether if you combine it with CMC, with HA, whether it would work. Yes, so they found that a combination of HA with Trehalose, it does promote an exit from the vicious circle of dry eye by promoting better tear film stability. And as I told you, it's also osmoprotectant and an anti-inflammatory. So this combination has various effects on the eye. It reduces ocular discomfort, increases tear film stability, surface damage, improves goblet cell density, and significantly reduces markers of inflammation. Dr. Rohit Shetty told you about those unpronounceable markers of inflammation, cathepsin and IL-2, IL-6, IL-9, and so many others, MMP9. So this has an effect, and there are published articles which show that HA with Trehalose has a synergic action in targeting various entities. It gives you a 5-point relief edge over monotherapy, better symptomatic relief, as you can see. And at day 35, the combination is better than just HA alone. And at day 84, also at 78% better. Patients felt better. So better reduction in severity score. So when you did the OSDI index, the severity score, the combination fared better. Patients were more satisfied with the combination over monotherapy. And faster corneal reepithelialization. You know, we need to get the cornea reepithelialized in many conditions where there is dry eye with epithelial loss. So the number of days it took in the combination group was just 2.3 days as compared to just HA alone, which was 3.8 days. So this also, and it's well tolerated. it is almost as well tolerated or little better tolerated than HA alone. So there are no significant side effects to this combination. Now, suppose to this 2-in-1 that we have, HA with trehalose, we add some other excipients like taurine, L-carnitine, glycerin. These are all osmoprotectants like the trehalose itself. And you then top it up by making it preservative free. Then you get further protection against hyperosmolarity. And the glycerin has a dual effect as well. So the osmoprotective role, as we know, the tears in a dry patient become hyperosmolar. These osmoprotectants like glycerin, L-carnitine, taurine, and even trehalose, they're tiny molecules. They get into the cells, hold the water inside the cells, and say, "Main aapko nahi jaane dunga." So it prevents the water from exiting from the cells, in spite of there being a desiccating stress. So osmoprotectants added to this formula of HA with trehalose truly give a 3-in-1 protection. And then you have essential electrolytes like potassium, which are also important. And you throw in a little bit of vitamin B12, and which is also decreases stress and inflammation. And you make it preservative free. Then you've got a lot of, at least in theory, a lot of ways of preventing worsening of a dry eye condition by having one drop which is preservative free, which has HA, trehalose with osmoprotectants and essential electrolytes and vitamin B12. This would therefore add a new dimension in the management of dry eye disease. I thank you so much, and I apologize if I've overloaded your brains. Thank you.
I think that was a wonderful presentation, sir. You really simplified the whole thing very nicely. And I think now the session is open for question answers.
Yeah.
I would like some comments from Dr. Namrata before we finish. So if there are questions, we can take them. Otherwise, some remarks from Dr. Namrata.
Sir, I think it was a great webinar and the talks were all very good. And we are thankful to all the faculty members who are here with us and have stayed for such a long time. Normally, people don't stay for the whole webinar, but thankfully, and all the talks were good. I'm sure the questions are going to be great. And again, thank you once more for organizing this, Bhupesh and Rushad, and you, sir. Thank you so much.
So there is a question for Dr. Rohit. If COVID virus can be in epithelium, then should we be PRK post-COVID in the COVID era?
Yeah, I think Rohit has already answered that, Dr. Balla.
Okay.
So, Rohit, your take on topical chloroquine in dry eyes. I know that you've done a lot of work on topical chloroquine. In which part of dry eyes would you use this?
Basically, topical chloroquine works something similar to what you just said, cleaning up the dead cells, basically. When your cells are dead, and they are the ones who produce unwanted inflammation. So chloroquine and trehalose has a very similar combination, but they don't act on the same pathway. They're two different pathways. So you cannot mix a chloroquine drops with a trehalose drops, even though one is a lubricant. Unlike you mix a restasis or chloroquine, cyclosporin with the hyaluronate, UV lube or chloroquine drops has to be not mixed with, because they fight against each other. They are very useful for patients who come to you with less of signs and more of symptoms. So they are extremely useful in that way, and also useful when you see a lot of corneal staining. The epithelial cells are at stress.
Yeah, Rohit, I've also found it useful in photophobia.
Exactly.
So typically, my patients with photophobia, I would straight away jump to chloroquine for that. As you said, symptomatic, you might not find anything much on the cornea staining, but they can't stand light. They do very well with chloroquine.
I think we've done a study in post-LASIK cases where we've compared chloroquine with cyclosporin, and we found the results to be similar. And likewise, for chloroquine, we are also studying in cases of allergic conjunctivitis. And I don't know how far it will help in the COVID conjunctivitis. That is something which remains to be seen.
I think we've almost answered everyone's questions. Yeah,
Can I
Rohit.
give you one take on ma'am's thing about, she gave a very nice question about can it be used in COVID conjunctivitis? Based on how it works, it may not really work it will not may work for COVID conjunctivitis because it does not work when the virus is already in the cell. It works only when it's trying to enter the cell. The whole action is catapsin pathway, when I said, is this, when it's trying to go in. So it may be more like a prophylaxis than actually kill. It cannot kill the virus once you already enter. That is what my take is at this point.
I think that also is from the extrapolation of the systemic thing, where again it acts as a prophylaxis and not as a curative for the COVID systemically.
There's another question. This is for Dr. Rajiv. What is the cutoff value for posterior corneal flow to diagnose post-LASIK ectasia?
As I said, in that case, can I just share my screen and bring up the presentation if it's okay?
Yeah, please.
I think ever since the webinars have come up, it's become a lot easier to explain topographies to people, pentacams and things like that, because they're looking at their own laptop. So you don't have to, magnify the figures. They themselves are magnified. So it's become much easier to do these kind of talks and to explain. We can't see your screen, Rajiv.
Yeah, just. So basically, this is the cutoff value. If you see, 2 standard deviations is about 13 microns, and 3 standard deviations is about 18 microns. So this is what brings you into that red zone of red and yellow zone of the D values of the posterior corneal ectasia. But I usually don't go by these numbers. As I told you, what I do is I would rely on the Bellin-Ambrosio enhanced ectasia map, and then just analyze the posterior corneal surface to see if there's an ectasia, and I go by the dB value. Number 2 is, I think these are the only 2 things, and you can always go into the Artmax and the progression index to see if it's really abnormal for that case. If it's less than 1.2 progression index, I would say it's normal. And if your Artmax is more than 385, I think we are in a safe zone. So these are the 2 things. I mean, if you really want to quantify in terms of the figurative value of 13 microns and 18 microns, then that may be it. But then I would analyze it differently.
There is a question for cross-linking. So if there is a steepening after cross-linking, when we can repeat the cross-linking? What should be the interval between the 2 procedures?
So, I think I will be the right person to answer it. So at least there should be a progression in cross-linking between 2 readings, which I would suggest that it should be about 6 months apart. And if you're seeing that there is a progression in keratoconus after cross-linking, I have not seen in my own cases any progression after cross-linking, but there's a possibility that someone has done epi-on cross-linking or something else, maybe pregnancy. And in all these cases, sometimes there is progression which is documented. And then in those cases, we have to show that this keratoconus or ectasia is increasing, and then we can probably do a repeat after maybe 6 months.
I think one more thing that we can look at is whether there's any scarring or any haze, because that also affects your values that you get on the pentacam, because the shine flood causes a backscatter. So sometimes just a mild haze may also affect it may not actually be progression. It might just be a false reading that you're getting. So I think you should look at that a little carefully, both on the slit lamp and on the pentacam with the densitometry reading that you get on that.
it is something more to be seen if you're doing a transepithelial. Even I have not had a single experience where I have done a repeat cross-linking in my patients.
No, there is a study, the Whitting de Silva study also said that progression has happened associated more with patients who have eye rubbing and also patients who had neurodermatitis or collagen vascular disorders. So those things have to be ruled out. Also, there is if there's a decentralized cone, which sometimes after cross-linking tends to centralize. So the central K can sometimes go up, even though it's a regularization. That must not be mistaken for progression either.
There is a question. If you don't get the
this is where we had to repeat.
Question for Dr.
proper
Bhupesh.
effect of ICRS.
Yeah,
Just one
Dr.
last
Bhupesh.
question for Dr. Ritika.
There's one.
If there is
Can I ask you a
no
question? What is IOL for choice? IOL of choice in patients undergoing cataract surgery, patients with keratoconus. What is the IOL of choice in those patients?
So you're talking about IOL power with triple procedure or just
in triple procedure.
In triple procedure.
Yeah.
So ideally we should go with the monofocal IOL because we don't know what we're going to get after keratoplasty. So if we don't have any other options, we have to go with monofocal, do keratoplasty. When we get the post-op result after suture removal, then we can think whether we need to give glasses or contact lenses. So monofocal is the choice of lens for triple procedure.
And what is the keratometry which you would like to depend on, the true keratometry of IOL Master 700 or EKR?
So
Pentacam.
Always better to have an optical system like LensStar or IL Scan. We cannot go with the contact one. So optical is always better.
However, if you're doing a triple procedure, the question of K reading you'll have to use a standard K.
It does not arise.
Normal cases we are talking.
Normal.
So one question for Dr. Ritika also.
And look with the 3 millimeter optic zone.
Yeah.
If the effect of ICRS is not adequate, can we replace it with another ICRS to get the optimal results?
Actually, that's a tricky bit.
Yeah.
Because you never know what the ICRS is not mathematics. Some people respond better to ICRS. It's not like a excimer laser where you can predict the effect. So not adequate is, this is very difficult to judge it against. Of course, I've never really, if you repeat it, you have to basically replace it with a thicker segment. I have not heard of anybody really do that.
I have had
you could
couple of cases.
You could do a fake ICL in these cases.
Yeah.
Yes, that you can after don't centralize. Yeah, that is what we've also done because, but we never really enhanced the effect of ICRS by replacing it with a thicker segment.
Have you had any cases where you did ICL, especially in cases of post-LASIK ectasia, and there was no change at all?
Okay, ICRS?
ICRS.
We've had cases with less change, and there are patients who've actually had much more flattening, and there is some degree of unpredictability that comes in. In fact, I'm now trying to do the pre-op biomechanics also, because sometimes the poorer biomechanics may actually enhance the effect of the ICRS flattening. So there is no mathematics that we've seen. I've had a very wide variation in terms of the duration and the effect both with ICRS. Certain patients show flattening within 3 months, and certain patients have shown no flattening for 1 year and then have started flattening after 1 year. So it's a very wide variation which we've not completely understood. And they all behave a little differently.
It's a question, what is the role of Corvus in diagnosing keratoconus or form fruste keratoconus?
Maybe Rohit sir can.
Rohit sir.
Dr. Rohit sir.
Corvus is just definitely one more indicator to understand biomechanics a little better, but it doesn't mean that if the TBI is on the red, I would not believe that cornea is truly ectatic. It has to be a combination of factors which make me understand. So whether it's Corvis or ocular response analyzer, these are all very much on the tips of the iceberg as far as measuring biomechanics.
I think understanding of biomechanics, we are planning an international webinar on it, and we are doing a masterclass sort of a thing, and I think that's going to be there somewhere next week, and so we'll keep you posted on that.
Any other questions we have?
I request you, Dr. Bhalla, to go ahead with the vote of thanks.
Yeah, sir. I think it was a wonderful webinar. Thanks to one and all for your contribution, sir. And it's my privilege it's our privilege, in fact, from DOS to have such a wonderful and informative webinar under the aegis of Delhi Ophthalmic Society. Sincere gratitude to Dr. Bharti, sir, for organizing and providing us opportunity to interact with galaxy of eminent speakers. We had them all, sir. Dr. Bharti, you are pioneer of refractive surgery in India. Dr. ophthalmologist par excellence and translational scientist from Narayan Netralaya. Dr. Chitra Ramamurthy, the dynamic chairperson of ARC-AIOS and director of Eye Foundation Group of Hospitals. Dr. Rajiv Mukherjee, Dr. Ritika, Dr. Rushad, Dr. Bhupesh, their lucid talks really set the momentum of the webinar. Dr. Quresh, sir, your unparalleled knowledge, your wit, humor, parallels the talent in all fields, sir. And Dr. Namrata is omnipresent. What more to say about her, sir? If she is not writing guidelines, she is writing papers. And if I was just surveying to find Dr. Namrata, and lo and behold, I found her on the cover page of Survey of Ophthalmology, sir. So by our humble, graceful, and ever-smiling President, Dr. Mahajan, who has always been pillar of strength for academics and all the activities of DOS. And last but not the least, I think our delegates have, true to the title of the webinar, they had all the questions on keratoconus answered for them by the eminent galaxy of speakers. And I would also like to thank our sponsors, Ajanta Pharma and Mr. Suresh Pandey, for helping us organize this blockbuster on keratoconus. Thank you, everyone. Thanks one and all, sir.
Thank you, Dr. Bhalla. Your vote of thanks was excellent. It couldn't have been better than this. Super.
Thank you, ma'am.
Thank you so much.
Thank you, sir.
Dr. Bharti.
Thank you, everyone.
Thank you, everyone.
Very nice.
Okay.
Thank you, Dr. Rohit, sir. Thank you, Dr. Chitra.
Thank you all.
Thank you, everyone, sir.
Thank you.
Yeah,